Hi, my name is Dr. Sherry Pearson. I'm a psychologist in the community, and I'm going to be talking to you about the mental health of the autism spectrum community, how we can catch it and treat it. This talk is hosted by Florida Atlantic University Center for Autism and Related Disabilities, PEPSA, Partnership for Effective Programs for Students with Autism. The mission of CARD is FAU Center for Autism and Related Disabilities provides expert consulting, training, and support at no charge for all people across all race, ethnic, and gender groups with autism and related disabilities, their families, employers, the professionals, and community and governmental agencies serving them. The vision, FAU CARD provides support and assistance with the goal of optimizing the potential of all people across all race, ethnic, and gender groups with autism and related disabilities. FAU CARD serves 5 counties, including Indian River, St. Lucie, Martin, Okeechobee, and Palm Beach, with 3 offices in Boca Raton, Jupiter, and Port St. Lucie. The services offered at no charge include family and school consultations, trainings and workshops, public education, referrals and resources, adult hangout groups, and much more. So that leads us to our talk now. So as I said before, the talk is the mental health of the autism spectrum community. And we are going to be discussing 3 main areas today: the variability of mental health symptoms in people with autism spectrum, or ASD, the evaluation process involved either in diagnosing autism spectrum or other conditions along with autism spectrum, and a variety of treatment options available to support individuals with ASD and their families. So, ASD is often misdiagnosed. It shares symptoms with other conditions, which can result in confusion and missing the diagnosis. There's a term called diagnostic overshadowing, which basically means the attribution of ASD symptoms to a co-occurring disorder. So what I'm going to be doing now is discussing some conditions that present similar to autism spectrum and often overlap with autism spectrum. And I'm also going to be talking about how they may be different from autism spectrum. So we'll start with anxiety. Now, with anxiety, we have many different kinds of anxiety disorders. We have social anxiety disorder, which is going to be talked about in a little while, where the trigger is socialization. There's separation anxiety, where the trigger is separating from mom or dad. There's generalized anxiety disorder, which is more of a generalized worry about everything. There's obsessive-compulsive disorder, which we are going to be talking about soon, which involves more repetitive compulsions and also obsessions. There's post-traumatic stress disorder, where the trigger is trauma. So there's a lot of different anxiety disorders, and they each have their own triggers. Now, there is also anxiety present among people with autism spectrum, but that anxiety, the trigger for it may come from a different place. So for example, many individuals with autism spectrum demonstrate emotion dysregulation, which basically means that they struggle to cope with and manage their emotions. What often happens with these individuals is they are so overwhelmed and overstimulated by their environment that they're not as in tune to what's happening internally, and they may not experience or realize that they're getting more and more stressed until they're an 8, 9, or 10 out of 10. And as a result of that, they experience these meltdowns or rages or tantrums that can really look pretty scary for the outsider and also feel pretty scary for the person experiencing them. And they experience them as a lot of anxiety, similar to an anxiety disorder. Now, also, individuals with autism spectrum experience anxiety due to difficulty coping with change or transitions. So that is a little bit of a differentiation between just a regular old anxiety disorder and autism spectrum in terms of the manifestation or reason for the anxiety. So the next type of anxiety disorder we're going to discuss is obsessive-compulsive disorder. Now, the obsessive-compulsive disorder involves repetitive behaviors, as does autism spectrum. But with autism spectrum, the repetitive behaviors can be associated with stimming. What I mean by stimming is finger clicking or hand flopping or rocking back and forth. Those kinds of behaviors often present when an individual on the spectrum is feeling excited and or anxious. and it creates just a way to release their emotions. Now, with obsessive compulsive disorder, their repetitive behaviors serve to decrease discomfort and provide a sense of control. So, for example, individuals with obsessive compulsive disorder may repetitively check locks because they're just not sure that the lock was checked, and they have to do it a certain number of times or else they feel something bad will happen. Or they need to wash their hands repetitively because they have contamination fears. And if they don't do it the way that they thought they were supposed to do it, or the number of times they thought they should do it, then something bad would happen. So what happens with obsessive compulsive disorder is that there is a sense of control that comes from doing these repetitive behaviors. That is different than stimming, which happens with autism spectrum disorder. So there isn't that sense of control or a need to decrease discomfort with stimming. Social anxiety disorder. So with social anxiety disorder, we have fears of rejection and fears of embarrassment that result in social avoidance. Now, a lot of individuals with autism spectrum demonstrate social anxiety, and that could be due to a lack of social skill. It could be due to rejection that they've already experienced. These individuals may also avoid socializing. Sometimes they avoid for the reasons of fears of rejection or embarrassment, but they may also be avoiding due to feeling overwhelmed by sensory stimulation in the environment. They may also just be disinterested in socializing in that specific situation because maybe it doesn't involve a special interest that they have. Oppositional defiant disorder is another condition that is often confused with autism spectrum. What I mean by that is I do a lot of psychological evaluations for children, adolescents, and adults. And a lot of parents have come to me looking for evaluations to try and figure out why their children are demonstrating such significant behavioral issues. Now, with oppositional defiant disorder, you see oppositionality, defiance, difficulty with authority figures. And what we find is that these symptoms typically decrease with age or turn into conduct disorder. With autism spectrum disorder, the rates of oppositionality and defiance are more consistent, and they do not become conduct disorder. Now, conduct disorder involves something important, and that's impaired empathy. So in conduct disorder, you often find people violating the rights of others, meaning people or animals. Now, individuals with autism spectrum may also demonstrate difficulty with empathy, but that does not result in them violating the rights of others. So that is a distinction between those two conditions. ADHD. Now, I can't tell you how many people have walked through my door having their child evaluated for ADHD. And then some of those people, not only do they get diagnosed with ADHD, but also with autism spectrum. And there's a reason for that. Symptoms of ADHD, including inattention, hyperactivity, and impulsivity, occur in 41 to 78% of youth with ASD. So there is this overlap. I believe it's because both of these conditions are associated with the frontal lobe of the brain. And the frontal lobe is in charge of so many things, including our ability to focus, our ability to manage our behavior and impulses, our social skills, our planfulness, our organizational skills, all those things that overlap and are involved in both of these conditions. Another condition that we're going to talk about is bipolar disorder. So bipolar disorder involves agitation, which can look like angry rages or meltdowns, sleep disturbances. Now with mania, you may see a lack of need for sleep, whereas with depression, you may see oversleeping, sleeping too much, or difficulty falling asleep. You may also find impulsivity or reckless behavior that often happens during periods of mania. There's also significant talkativeness in the form of pressured speech, which is talking really, really fast, and distractibility. Those things are often found among bipolar disorder. However, they're also found among people with autism spectrum disorder. So the emotional outbursts that we find with autism spectrum may look like anger rages, they may look like these meltdowns that we see during mania, but they're due to different reasons. So in individuals with autism spectrum, these meltdowns could be due to sensory overload. They're just overwhelmed by all the sensory stimulation in their environment. They're overwhelmed from masking all day. Now, masking is something we're going to talk about in a little bit, but it basically involves putting on a mask or trying to camouflage with a neurotypical population, which can be very exhausting. And also, emotion dysregulation, which is something that we already talked about. And that's different from the emotional outbursts or meltdowns or rages that may occur in somebody with bipolar disorder, because that's coming from more of a chemical place. Also, we have sleep disturbances with bipolar disorder and with autism spectrum. Now, with bipolar disorder, as I mentioned before, we have different types of sleep disturbances depending on whether we're dealing with mania or depression. Whereas with autism spectrum, their sleep difficulties are not directly related to a mood state. They're more just associated with the condition themselves. So a lot of individuals with autism spectrum may struggle with falling asleep or staying asleep because their sleep rhythms are just off. In addition to that, we have pressured speech, which we often see in mania, which basically involves people talking very, very fast. It may be difficult to understand them, versus hypertalkativeness and lack of reciprocity that we see with autism spectrum. So with autism spectrum, you may see people talking a lot about their special interests, but they may not be talking so fast that you can't understand them. The talking a lot about their special interests, though, does interfere with reciprocity at times because it appears more like they're talking at you as opposed to having a back and forth flow in conversation. Also, bipolar presentations are episodic and cyclical. So we're having a depressive state and we're having a manic state, and we go back and forth between those states. Whereas with ASD, the behaviors that you see and the mood states that you see, they're more chronic and they're more persistent over time. So one study found that psychosis and bipolar disorder occurred at a higher prevalence in adults with autism spectrum compared to the general population, basically saying that individuals with autism spectrum may be at greater risk for developing psychosis and bipolar disorder. This same study found that males had an increased likelihood for co-occurring psychosis, whereas the females had an increased likelihood for co-occurring bipolar disorder. So the next condition we're going to talk about is schizophrenia. Now, back in the day, there was a lot of confusion about autism spectrum. And I think people didn't quite understand what it involved. And so a lot of individuals with autism spectrum were misdiagnosed as having schizophrenia. And I'm going to talk a little bit about why. So with schizophrenia, you see hallucinations, right? They have the auditory hallucinations, they hear voices that aren't there, visual hallucinations, seeing things that are not there. Now with autism spectrum, they have special sensory superpowers. They can be hypersensitive to sensory stimulation. They may hear things that you and I, who are neurotypical, may not be able to hear, but that doesn't mean that they're not there. They're not hearing voices that are not there. They just may be more in tune to certain sounds. Same thing with light. They may be more sensitive to light. They may be more sensitive to texture in their food or in their clothing, but that doesn't mean that it's not there. Also, with schizophrenia, we have delusions. So you may have paranoid delusions where people think people are out to get them, or delusions of grandeur, where people think that they have special powers. And in these situations, it's them thinking that they can do something that they can't. Now, with idiosyncratic thoughts that you find among autism spectrum, that's different. This is just them thinking about the world a little bit differently. Their social cognitions are different, and it doesn't necessarily mean that they're out of touch with reality. Another difference that we find is that with schizophrenia, there's disordered speech. So you may see loose associations where it's really hard to follow their train of thought. They're not really making any kind of clear communication. With autism spectrum, you can follow their train of thought, but sometimes their pragmatic speech differences interfere with conversation because they tend to get hyper-focused sometimes on certain topics, and that can interfere with reciprocity. So the next thing we're going to talk about is psychosis. So one study found that differences in social functioning can increase experiences of bullying, which may then in turn increase stress levels, placing somebody at greater risk for experiencing psychosis. So basically what they're saying is that because these individuals are different in the way they interact with people, they may be more at risk for being targeted by bullies, increasing their stress, possibly resulting in some sort of depression, and then subsequently experiencing psychosis. So clients that struggle with an awareness of their emotions, which is something that I was talking a little bit about with the emotion regulation, may be blindsided by intense experiences of distress, which could then predispose them to psychosis secondary to a mood disorder. So I'm going to give you an example from my practice, from my personal experience at work. I had a client who was an adult who came to me looking for an evaluation, and she knew she had autism spectrum. She'd done her research, and she just wanted to be validated that that's what was actually going on. So I did do the evaluation. I validated her thoughts. She definitely has autism spectrum. And at first it seemed that she was relieved, but shortly thereafter, I guess she became very overwhelmed with the what ifs. What does this mean for my career? What does this mean for my relationships? And she subsequently, because I think it caught her by surprise and she didn't have the coping skills intact in order to cope with all of this anxiety, she did have a psychotic break. And that's not to say that everybody who finds out that they're going to have autism spectrum is going to react in this way, but this individual just was blindsided by intense emotions, and that predisposed her to having psychosis secondary to a depressive episode. The next thing we're going to talk about is borderline personality disorder. Now, borderline personality disorder has certain overlaps with autism spectrum. Both of these conditions can result in difficulty with emotion regulation, which we've talked about, difficulty with empathy, which we talked a little bit about and I'll talk about more soon, intimacy, and also results in interpersonal difficulties. Now, one of the commonalities between these conditions is this theory of mentalization. Mentalization is the understanding of others' behavior as motivated by beliefs, wishes, and fears. So what are the intentions behind your behavior? And what we find is that people with borderline personality disorder only struggle with mentalization during periods of increased emotionality. When they are experiencing significant stress, they have a hard time understanding why people do what they do. Whereas with autism spectrum, the difficulty with mentalizing is occurring more consistently. So they struggle with understanding others' motivations, wishes, fears, beliefs because of that difficulty with empathy that we discussed. And that is more of a consistent difficulty for them. So unfortunately, a lot of individuals with borderline personality disorder may go on to develop something called self-harm, which is a strategy used to regulate unbearable emotions and fragmentation of the self. In my practice, I had some teenage girls who demonstrated self-harm. They would report to me that they experienced such severe emotional distress that they needed to have a physical outlet for that emotional pain, and so they would cut themselves. So what we find, or at least this study found, is that when mentalizing is compromised, individuals may not seek support from others because they can't imagine that somebody else would understand how they feel and want to help them. And so they don't get the help that they need, which results in a higher incidence of suicide attempts and self-harm. So individuals with both ASD and borderline personality disorder might both be at risk for suicide because of this difficulty with mentalizing. So now we're going to switch gears a little bit and we're going to talk about adolescence, which is a difficult time for everyone. We all struggle with independence and fitting in during this period of time, but this time period is especially challenging for individuals with autism spectrum. So their socialization differences may become more apparent during adolescence due to this enhanced complexity of social interactions and the need for increased competence in navigating social situations. What I mean by this is that, let's say you're thinking about boys. When boys are little, there's a lot more parallel play happening. They may be playing with Legos next to each other. They may be playing video games next to each other. They may be doing sports. Even doing sports with each other does not require a lot of social communication and a lot of conversation. As you start getting towards those teen years, those conversational skills are very important. And in addition to the conversational skills, we really have more need for empathy, more need for interpreting social cues, and those things are more challenging for these teenagers. So individuals with autism spectrum may demonstrate interpersonal difficulties due to difficulty interpreting social cues or reading the room. For example, if let's say there's a 10-year-old boy and he is talking on and on and on about dinosaurs to his friend, and that friend is rolling his eyes, yawning, and trying to change the subject, that 10-year-old may not read the cue, oh, maybe I should change the subject and stop talking so much about dinosaurs. Also, individuals with autism spectrum may demonstrate different conversational styles. They have a harder time with that back and forth conversation. Sometimes they have a harder time initiating conversations, And I've been told by some of my teen clients that they really struggle with keeping the conversation going. So that means conversations may fall flat, get stilted, get uncomfortable, and then others may not choose to converse with them quite so much. Also, individuals with autism spectrum may demonstrate a tendency to be more literal. They may struggle with sarcasm, and sarcasm is pretty big during those teen years. So if, let's say, we have a 13-year-old girl, her friends are joking around and they're being sarcastic, she may not always know whether they're being mean or trying to be funny. And that can result in misunderstandings that hurt feelings and affect relationships. Individuals with autism spectrum may also demonstrate difficulty making and keeping friends. The reason for this is because their interests make them a little bit different from their peers. So for example, I had a 15-year-old girl who I evaluated the other day, and her interest is unicorns, and that's all she's interested in. And she wants to make friends with other people who have that common interest. They're also into unicorns, but it's a little bit more challenging, as you can imagine, to find a 15-year-old who's interested in talking on and on about unicorns. So finding that common ground may be more difficult, and also having that depth in the relationship may be difficult. Some of the teenagers that I've talked to that are on the spectrum have a harder time talking about dating and that piece when it comes to their relationships. And that's because some of them are just not there yet and don't have that interest. So they really can't. And because of the empathy difficulty, they have a hard time sticking with it. If they're not interested in that yet, they have a hard time sticking with it to discuss those kinds of things with their friends. Also, individuals on the spectrum or teenagers on the spectrum may not always adhere to social norms. So for example, I had a teenage girl come to her evaluation the other day with her stuffed animal, and she saw nothing wrong with walking in with her stuffed animal. I've also had some teenagers come to my office talking on and on about dinosaurs, and that might not be something that you would expect a teenager to be discussing when they come for an appointment. So because of those unexpected behaviors, they may not receive social acceptance. During the teen years, individuals with autism spectrum may use masking to camouflage their autism spectrum and improve the ability to blend in and increase social acceptance. So some of the kids on the spectrum that I've met are like, this is me, take it or leave it. And then there are other kids that are tired of being rejected or ignored. They really want to make friends. They want to blend in. And in doing so, they try to alter their social behavior in order to cope with and become part of the non-autistic or neurotypical social world. Oftentimes, these individuals will say, look, I got too many negative responses to my natural instinct or behavior, so I'm going to change that because I just want people to like me. So people on the spectrum, especially a lot of the teenagers that I've worked with, will report being very observant. Some of that is a protective mechanism. They're always looking out, looking around their environment because they want to make sure that they're not doing or saying the wrong thing. They're also very caring individuals, but being observant and being caring is different than empathy. And difficulty with empathy can result in difficulty blending in or camouflaging. So I'm going to give you some examples that my clients have reported using when trying to mask or camouflage. I've had teenagers tell me that they look at a point between the eyes or at the nose instead of the eyes because looking eye to eye just feels too intense. Some of them will put on a happy face despite internally feeling extremely anxious. I've had others use fidgets to decrease restlessness that they're feeling due to the anxiety associated with socialization. I've had some male teens tell me that they use slang phrases that they've heard their friends use in conversation, which can sometimes backfire, as you can imagine. If they use it wrong or at an inopportune time, that definitely doesn't work in their favor. Other clients have practiced using interested faces in the mirror in order to ensure that they don't give themselves away, because oftentimes they'll report to me that if it's not really about their special interest, that they're not really all that interested. And so in order to blend in and pretend, they have to look interested, even though internally they're bored to tears. So what's the downside of all this masking and camouflaging? Well, my teen clients have reported feeling like a phony and feeling exhausted by faking it all day, every day with their peers. And their parents have reported to me that these teens come home having meltdowns because they just can't hold it in anymore. On a more serious note, studies have found that camouflaging autistic traits can be associated with increased risk of experiencing unmet needs to belong and increased risk of suicidality. So because they're pretending all day long to be somebody that they're not, they don't truly feel like anybody gets them or really wants to be with them. They want to be with the person that they're pretending to be. And as a result, these individuals may experience significant loneliness, which could result in depression and an increased risk of suicidality. Another study found that the risk of suicidality is associated with social communication impairments, but not with the ASD itself. So my idea here is that because these individuals struggle socially and struggle with communication, they may experience more rejection or bullying, which then could result in depression and suicidality. Another study found that in the ASD group, greater emotion dysregulation was associated with suicidality. So as we've talked about multiple times, emotion dysregulation plays a significant role in autism spectrum, and not being able to regulate those emotions can send us into a bit of a tailspin, and it might result in some individuals experiencing significant depression, which then could result in suicidal ideation. And lastly, even though ASD subjects die of suicide and present with more self-harm than do non-ASD subjects, one study found that the association was explained by their comorbid psychiatric disorders. So a lot of my clients that I've diagnosed with autism spectrum are also diagnosed with anxiety disorders or depression. And as a result of these other disorders, this study is saying it was the unmanaged depression or the unmanaged anxiety that resulted in them taking this turn towards suicidality and self-harm. So now we're going to switch gears a little bit, and we're going to talk about a different period of time that can be challenging for individuals on the spectrum, and that is the transition to college. The reason that this transition can be challenging is because it involves difficulty balancing academics, the social demands, specifically of having a roommate, and independent living needs. So for example, I've had quite a few clients of mine transition into college, and I'm saying clients with autism spectrum that have transitioned into college, and they will talk about really struggling during college. And I'm going to talk in a little bit more detail about some of those struggles and why. So one of them is involving limited executive functioning. As I said before, ADHD and autism spectrum have a lot of overlap, and that overlap involves difficulty with executive functioning, which is organizational skills, study skills, time management. So the adult male that I'm referring to who went away to college, he has really struggled with planning his time out so that he can get his assignments done. There's a lot of procrastination. There's a lot of anxiety resulting from that procrastination. When he was living at home, mom was kind of looking over his shoulder and making sure that things got turned in a timely fashion, that he was studying when he needed to be studying, that he was avoiding distractions. And now there isn't anybody to look over his shoulder and provide that additional support. Another difficulty when transitioning to college could be difficulty coordinating social plans with new people. So I have another client, a female client, who went away to college, and she was very excited for the experience. But what she wasn't thinking about was the fact that when she was in high school, she had her few close friends who had her common interests, who understood her and accepted her for who she was. And now she has to go out into the world and make new friends and find people who are like-minded, which isn't always easy. And I think it can be even more challenging for individuals on the spectrum. And so in addition to having to go out there and make new friends, which can be hard, she also had to plan to socialize with these individuals. It wasn't like they were all going to be in class together for 7 hours of the day, or they were all on the same athletic team, or they were all in the same club. Plans had to be made to meet up for dinner, to meet up for lunch, to go out on the weekends. And that was something that she wasn't as comfortable doing. So we had to practice quite a bit for that. Additionally, the need for additional downtime to decompress is a piece of the autism spectrum puzzle when we do have this transition to college. Both the female and male clients that I was referring to both struggled because they needed to find time to be alone in a quiet, sensory-friendly place. They were so overwhelmed with the academic and social and daily living demands that they needed to be able to come back to their room and just experience quiet and do whatever they needed to do to find peace so that they could go back out into the world feeling confident and ready to start their day. Well, unfortunately, both of these individuals had roommates. And in one of the cases, the female really struggled with coming home to a messy room, a loud roommate who was up all hours. And she ended up having to leave college and eventually come back and request a single room, which worked out much better because she had that opportunity for a long time. So one study found that social interaction training and independent living training were services that were frequently requested by parents of individuals with ASD. And the reason for this is because these individuals needed additional support in doing these social things that I was just referring to, making new friends, making social plans. They also needed additional support with the independent living. So I think every college student has to get used to doing their own laundry, figuring out where they're going to get their meals, if they need to go grocery shopping, or if they're going to a cafeteria or dining hall. But the individuals on the spectrum may struggle a little bit more with this independent living piece. Parents of these students with autism spectrum endorsed distinct challenges with self-advocacy, meaning speaking to professors, getting the accommodations and support that they needed, managing their emotions. So these individuals were more likely to maybe have meltdowns or experience severe depression and anxiety associated with this transition, and managing personal and adaptive skills, which might be remembering to shower every day, getting to bed at a reasonable time, making sure they're eating all the meals that they need to eat each day. And that's relative to regular post-secondary students that may have ADHD. So this was a study that looked at students with ASD and students with ADHD. Those with ADHD didn't quite struggle as much in the areas of self-advocacy, managing emotions, and managing personal and adaptive skills, as did those with ASD. So now we're going to switch gears again, and we're going to talk about when to refer for an evaluation. So I find three major things that would lead somebody down the road of an evaluation. Differential diagnosis. What's going on with my kiddo, or what's going on with me? Is this social anxiety disorder or autism spectrum? Is this ADHD and or autism spectrum? So there's a lot of different reasons that somebody might come into my office asking for an evaluation, but that's the first one. And then obviously, if we're trying to determine treatment options, we need to know what we're dealing with, right? So certain psychologists in our community specialize in autism spectrum, and they would be much better to use as therapists, as opposed to just the therapist who knows how to develop coping skills and do relaxation strategies. In addition to that, medication management. So if we're dealing with an anxiety disorder or ADHD or autism spectrum, we may be providing different types of medication to manage those different conditions. And so it's important to know what the diagnosis is in order to treat the individual appropriately with therapeutic options and also with medication. So in addition to referring because of those reasons, a lot of parents come to me because their children are struggling academically and they're looking for accommodations or special education services. Academic placement, they're trying to decide what school to send their child to depending on their level of functioning, how severe any of the reading, writing, or math difficulties are, and what supports are available in the community. Also, these parents may be looking for additional academic supports outside of school, such as tutoring, therapies, social skills groups, those kinds of things. So now I'm going to talk a little bit about what the evaluation process entails. For me, I'm only going to speak to what my evaluation process entails because everyone may be different in how they go about this. My evaluation starts with a clinical interview. Usually it's with parents when I'm dealing with children and adolescents. If it is an adult that I'm evaluating, I'll do the clinical interview with the adult. And sometimes they'll ask a family member or spouse or significant other to be present as well to provide their perspective. So in this clinical interview, I include developmental history. So I'm asking questions related to the very early years, walking and talking, speech development, motor development, those kinds of things, because if we are thinking about autism spectrum, those developmental stages may be impacted. Also academic history. So I'm looking to see the academics over the years, what was going on in elementary school, middle school, high school, and so forth. Where were the challenges and what worked in terms of the supports that they put in place. Medical history is also very important. In addition to looking at those things, I look at psychiatric symptoms. And when I say psychiatric symptoms, I mean, I ask about a lot of psychiatric symptoms. And the reason for that is a lot of parents will come to me saying, does my kid have ADHD? Does my kid have an anxiety disorder? Does my kid have autism? Does my kid have dyslexia? Well, the parents don't always know what to ask for. So one of the things that I'll do is I'll go through the symptoms of pretty much every condition under the sun during this intake. And then if I find that they've said yes, yes, yes to a lot of symptoms of a condition that they didn't come asking about, for example, autism spectrum, what I'll often do is I'll say, you know, you endorsed a lot of symptoms of autism spectrum. Has anybody ever talked to you about that before? Has anybody ever discussed autism to you as a possibility of something that your child is struggling with? Oftentimes, to be honest, if they haven't come specifically asking for that autism evaluation, a lot of the parents are surprised that they've endorsed symptoms of autism. In addition to these other things that I mentioned, I also look at treatment history. So I want to ask parents if their child has ever been in therapy, if they've ever been to a social skills group, if they've ever received psychiatric medication for any reason, and how all of those things went. The next part of the evaluation process involves testing. So my testing starts off in the morning with an IQ test. And the IQ test is not just to see how smart your individual child or adult are. The IQ test tells you a lot of information. It tells you strengths and weaknesses, it looks at attention skills, and it also looks at processing speed. The second hour of my testing usually involves the academic achievement. So this is the reading, the writing, and the math. Now, I am going to be assessing for learning disabilities, but in addition to that, I'm also looking for patterns of difficulty. So for example, children with ADHD may struggle with reading comprehension, not due to difficulty understanding what they read, but actually due to difficulty with spacing out while they read, so they didn't absorb the information. Or there might be a child with ADHD who knows how to do math, no problem, but when it comes to word problems, they have a really hard time teasing out the most important details in order to figure out what operation to use to solve the problem. Same thing with writing. They may have good spelling skills, good grammar skills, but then organizing their thoughts in written form may be a bit of a struggle due to those executive functioning weaknesses. The next piece of my evaluation involves neuropsych testing. So the neuropsych testing, in my opinion, is a very important piece of this puzzle because it provides information about attention, visual and auditory, memory. Now with memory, what I like to do is 3 different types of memory tests. I like to look at what works for this individual, what kinds of, whether it's visual cues, repetition in practice, story context. I don't just want to tell parents or individuals what's not working or where the weaknesses are. I want to tell them what is working and what's a strategy that might work for them in order to move forward and compensate for any difficulties that they may have. In addition, I'll also look at language. So language could be understanding multiple step instructions, being able to express themselves in a fluid manner. Also, sometimes I'll look at phonics if we're concerned about reading. Processing speed is a very important piece of the puzzle. A lot of people come to my office because they need extra time to complete their exams and standardized tests. A lot of individuals on the spectrum may struggle with processing speed as well. And fine motor skills. Fine motor skills are very important because they play into writing. And if our hands get fatigued because the little muscles in our fingers are weak, we may not express ourselves in written form to the best of our ability. And so it's very important to assess that piece as well, especially because sometimes individuals on the spectrum may struggle with fine motor. Another piece of my evaluation obviously includes the autism evaluation itself. So I do this in different parts. We have the childhood autism rating scale, which is completed during the intake. Usually that's done with the parents, and I'm just going to be asking them a lot of questions. Does your child do this? Does your child do that? Sample questions might be, how's your child with empathy? Is your child very literal? Is your child's emotional expression about normal, exaggerated, dulled? Does your child have any sensory sensitivities? Are they sensitivity to texture in their food or in their clothing? Are they sensitive to pain? Do they struggle with personal space and touch? Is there any difficulty coping with change? Those kinds of things. Then the social responsiveness scale is a questionnaire that I provide to parents and teachers. It is also provided to adults on the spectrum when they come and get an evaluation for autism. And what I will do in that situation is provide the social responsiveness scale to the client and also to a spouse, a family member, a significant other that really knows them quite well. Now, the benefit of this social responsiveness scale is it provides information to me about social awareness, ability to pick up on social cues, social cognition, or the way that this individual thinks socially. So is this individual very literal? Do they tend to be taken advantage of by others? Social communication, so that's the conversational piece. Social motivation, are they good about initiating conversations and joining group discussions? And then repetitive behaviors and restricted interests. So with this piece, we're looking at difficulty coping with change, any repetitive behaviors like hand flapping, rocking back and forth, any sensory behaviors, sensory seeking or sensory sensitivities, those kinds of things. And the nice thing is we found all this information on these 5 different areas, and we can look about what's going on in the school setting, what's going on in the home setting, what is this person thinking about themselves if we're thinking about the adult, and how do others perceive them if we're thinking about their family members or spouse. In addition, the adaptive behavior assessment system is often used when we're dealing with children because it looks at the adaptive skills that individuals on the spectrum may be struggling with, including conversation or communication, social skills, and daily living skills. Now, the last piece of this puzzle, which is a very important one, is the Autism Diagnostic Observation Schedule, 2nd edition. So generally speaking, everyone seems to enjoy this piece of the evaluation. It is much more relaxed. It involves me getting information about the ability to pick up on social cues, and that's done with picture books and cartoons, the ability to converse, and that's done with different activities. So I'm looking to see, does individuals struggle with responding to my comments or responding to my questions? Is the conversation having a pretty steady flow, or am I having to do a lot of work to maintain? Is the individual talking at me a lot, which interferes with that reciprocity? I also do a little clinical interview with the individual, and for that piece, I will be asking questions about friendships. I'll be asking questions about like what it means to be a friend. I may also be asking questions about their emotions, and not just the triggers for their emotions. So like what makes you feel sad, but what does your body do when you feel sad? And the importance of that piece is that a lot of individuals on the spectrum are not as self-aware about their emotions and what their bodies are doing to warn them, I'm starting to feel really upset, I'm getting more upset, and they don't realize it's getting bad until it's really bad, and then it can be very challenging to cope. Other things that we talk about on this clinical interview with the ADOS is future relationships. And especially with my teenagers, it's always interesting to me to see how they think about future relationships, if that's even on their radar yet. So we look at a lot of different things, but I'm really looking to see some concrete information about how they respond to certain situations in a social manner. Another piece of the evaluation puzzle could include the emotional evaluation. Now, this one is sometimes done in lieu of the autism evaluation if we're not looking to assess for autism, but I have done it in addition to the autism evaluation when we need more information about anxiety and depression and those sorts of things. So this involves a clinical interview where I'm asking the client information about strengths and weaknesses, family, friends, and I might go through some symptoms as well. In addition to that, I do 3 of what I like to call the backdoor approach, where I get information about how the client is feeling, their level of stress, their coping skills, their self-esteem, without them necessarily realizing what I'm looking for, because some clients are a little bit more guarded and some might not be as insightful. So one of these strategies involves the thematic apperception test or the Roberts apperception test for children. Both of these involve the client being presented with a picture, and then they have to make up a story about this picture. And each card pulls for a certain theme. So the story tells me how they're dealing with that issue in their life. Another piece here is the sentence completion test. So the sentence completion test is I say a bunch of emotionally laden sentences, but they're incomplete, and they have to finish my sentences with the first thing that comes to mind, which doesn't give them a chance to provide a canned response. They don't get to say what they think I want to hear. They just say the first thing that comes to mind. In addition to that, projective drawings are something that I'll use. Now, projective drawings can be really helpful. They're not looking at artistic ability. They're looking at the client's level of stress, coping skills, and self-esteem. In addition to the testing piece, I also provide rating scales, and I discussed the rating scales already when it comes to the autism piece, which was the CARS, or the Childhood Autism Rating Scale, the Social Responsiveness Scale, and the Adaptive Behavior Assessment System. Now, in addition to that, if I'm looking for ADHD, I may provide the Conners 3 rating scale to parents and teachers, or to an adult, and then possibly a family member. Also, the behavior assessment scale for children can be very helpful if I'm looking for information about emotions and behavior, and a little bit of information as well about attention and hyperactivity. So after the evaluation is done, I've gotten all my intake background information, I've gotten the objective data from the testing, I've obtained the information from the questionnaires, which tells me how the behavior is occurring across settings. Then I'm ready to provide a report and do a feedback meeting. Now, in my feedback meetings, we discuss results and we discuss recommendations. I may provide referrals for tutors, therapists, and psychiatrists, depending on what the situation is. I might also provide resources such as websites, books, and articles. So academic accommodations that may be included in my report could be extended time, so extra time for tests, extra time for standardized tests, that sort of thing. Preferential seating at the front of the classroom and away from distractions, single step instructions, so breaking instructions down into single steps and making sure that the child or teen understands what's expected of them. Supplemental teacher's notes or a note taker. So what I mean by this is some individuals with ADHD or autism spectrum may struggle with multitasking. Well, note taking is multitasking, right? You have to listen to what's most important that the teacher is saying and then jot it down. And in having to listen, pay attention, figure out what's most important and jot it down, you may miss some pieces of the lecture. And having supplemental notes from the teacher later on or from the note taker that was assigned to that college class could be really helpful so that that individual is studying the same information as everyone else in the class when it comes time for the test. Additionally, academic accommodations could involve academic interventions, which might mean if this individual, let's say, has dyslexia, they may need some kind of Wilson, Orton, Gillingham reading intervention, and that, depending on the school, could be provided during the school day, which is really helpful. Other accommodations could include the ability to use a calculator if there's a math disability, the ability to use audio or digital books if there's a reading disability, and the ability to use spell checker if there's a writing or spelling disability. Also, oftentimes when we're dealing with an individual with autism spectrum that may be demonstrating some of those behavioral issues we talked about in the beginning, having a behavior plan in place where the teacher and the parent are all in communication and have a plan in place to reinforce the child's positive behavior and target behaviors, that can be really useful in improving some of those behaviors in the school setting. In addition to that, support from a school counselor. I can't tell you how many of my children and teens with autism spectrum have a really rough time during their school day and could benefit from having a safe person in their school that they can go and speak to during periods of stress. In addition to that, I have advance notice regarding transitions. So as I mentioned before, individuals on the spectrum may struggle with coping with transitions or change. And so giving them a heads up, we're going to have an assembly later today. You may have lunch at a different time. We may be going to recess at a different time. That advance notice can make all the difference in preventing meltdowns. Also, having access to transitional support services could be very helpful. What I mean by that is that individuals, whether they have autism spectrum or other conditions, if they're in the public school system during high school, they can get hooked into vocational rehabilitation. And vocational rehabilitation can provide some transitional support when they are either transitioning to college, vocational school, or competitive employment. So other things that I might provide during this feedback meeting is my referrals. So I might be referring somebody for occupational therapy if they struggle with their fine motor skills or they demonstrate sensory issues, as do some people on the spectrum. I may also be providing referrals for speech therapy, especially to develop pragmatics or conversational skills, or needing to develop their expressive or receptive language development. Other things that I often recommend, especially when we're dealing with autism spectrum, is social skills groups. I think social skills groups are a wonderful opportunity for children and teens to practice their skills in a therapeutic environment. So usually it involves about 4 to 6 individuals. Sometimes it's same gender, sometimes it's different, where the individuals are working on different skills every week. They're practicing those skills in a fun manner with activities with their peers. And the nice bonus about these groups is that I found that a lot of my clients have found their people in these groups. They find that their social skills groups are their safe place, where they don't have to mask, they don't have to camouflage or pretend. Yes, they know that they need to learn these skills, but they find other like-minded individuals who get the struggles, who get where they're coming from. And a lot of these individuals look forward to going to group every day because it is a place that they feel is like home. In addition to the social skills group, I often recommend individual therapy. It's a great opportunity to develop an awareness of our body's emotional signals. That's something that I keep re-emphasizing, that a lot of the people on the spectrum may be blindsided by their emotions because they're so overwhelmed by their environment. Getting them to notice when they're a 5 out of 10 instead of a 10 out of 10 can help them to say, okay, I'm a 5 out of 10, my stomach's hurting, I feel a little sweaty, maybe I should go stop and do some deep breaths. That kind of thing can prevent serious problems later on. Also, individual therapy could work on developing coping strategies, self-acceptance, so being happy with who I am. We all come to the table with stuff, as I like to call it, and we just have to figure out how to compensate for our stuff and how our stuff sometimes isn't always a weakness. I tell people on the spectrum all the time that they have a superpower, that they have this ability to hyper-focus on their interest, and when their interest involves something involving their career, they can be very, very successful because they have this ability to hyper-focus. I also find that therapy is very beneficial when it involves developing confidence and self-advocacy skills. Whenever these individuals are transitioning to college, a lot of the conversations that I like to have with them is, how do we go about communicating to people, not just to professors saying, I need this accommodation, but how do I go about communicating to other people like my friends or my significant other, how I work and what works for me? Like I need to go to bed a little earlier. Sorry, guys, this is just me. Or sometimes I have a hard time doing this part of the conversation and I don't mean any harm by it. I don't want you to think I'm being rude, but this is a challenge for me. So figuring out how to communicate their needs and their difficulties so that the relationships go a little bit smoother. In addition to individual therapy, another option would be ABA therapy. Now, some people feel strongly about this in a positive way, some others don't. I've seen a lot of positives come from ABA therapy, especially with younger children, because it can provide intensive support in the home and school settings. And that can be great to provide parents with good strategies and also teachers, so that everybody's got tools to help and support this child. Now, one other thing that I think we need so much of, and I'm dying to provide, but don't have the time, is parent support groups. So many of the parents that I have been meeting with in my feedback meetings and sharing, your child is autism spectrum, they become very overwhelmed with all of the needs of the child. Okay, we need to do medicine, we need to do social skills group, we need occupational or speech therapy, we may need tutoring, we need individual therapy. This is a lot. And also this child may be difficult at home. They need to know that they're not alone, that there are other parents going through the same challenges, and hearing from other parents, this is what I did and it helped, could also provide them with a sense of peace. So if anybody knows of any good support groups, please pass the word along. When to refer for medication management. When there is impact on academic performance, relationships, and self-esteem. So this is a question that's often asked of me during my feedback meetings by parents. When do we medicate? I also tell them, I'll be like, listen, if your child's academics are suffering because they can't focus, if their relationships are suffering because they're so impulsive, they become annoying or create problems for themselves, or if their self-esteem is suffering because they're experiencing rejection from parents, siblings, friends, teachers, all of those are reasons to go down the road of medication management. All right, so thank you for participating in this webinar. To obtain a certificate of completion, you must fill out the form at the certificate of completion link provided on the email for this training. Please write down this code as it will be required to receive the certificate. S as in Sam, P as in Paul, 092022. The code is SP092022. All right, I'm going to continue with my conversation. In addition to some of those referrals that I provide, I like to provide parents with resources, including books such as Asper Girls by Rudy Simone, the Asper Kids Secret Book of Social Rules, What Every Autistic Girl Wishes Her Parents Knew, 10 Things Every Child with Autism Wishes You Knew, the Awesome Autistic Go-To Guide, a practical handbook for autistic teens and tweens, the Spectrum Girls Survival Guide, How to Grow Up Awesome and Autistic. I also got some good recommendations for adults on the spectrum, and these books are Neurotribes by Steve Silverman, We're Not Broken, Changing the Autism Conversation by Eric Garcia, and Living Well on the Spectrum, How to Use Your Strengths to Meet the Challenges of Asperger's Syndrome, High Functioning Autism by Valerie Gauss. In addition to books, I also like to provide websites. So Parenting Autistic Children with Love and Acceptance is a great blog. Respectfully Connected, another parent-oriented blog. Other websites that I've checked out are Neuroclastic, Musings of an ASD, Thinking Autism Guide, and The Art of Autism. I've checked out all of these websites just to get a better understanding of where individuals on the spectrum are coming from. These websites are created by individuals on the spectrum. There's a lot of great blogs that provide some good input about the struggles and also successes that come with having this condition. Another resource that I like to provide is Neurodiverse Love, which is a podcast about relationships in autism spectrum. There's also an online support group for individuals with autism spectrum located on Facebook. And listed below are all my references. Thank you for attending this workshop. Please contact FAU CARD at 561-297-2055 or CARD, C-A-R-D, at fau.edu. You can also look them up on the web at www.autism.fau.edu. Thank you.